So I think the original NAPOLI study demonstrated superiority with the use of the nal-IRI regimen over standard of care. So this abstract focused on a subgroup analysis looking at how the benefit panned out based on number of lines of metastatic therapy. So what it showed was that nal-IRI was most effective when used in the first and second line. There was also a trend for improved outcomes when used in third or subsequent lines of therapy as well. But the numbers in those subgroups are a little more limited. So I think the focus of the results should really be on the first and second line use. Well, I think clinically, because pancreatic cancer is still a very morbid disease with very few treatment options. I mean, I think in general, and, speaking on behalf of some of my other colleagues, I think most of us will want to use this regimen. I think the results are shown today in the abstract just confirms to us that perhaps most of the benefit is present or more evident when used in the earlier lines. The original NAPOLI study focused on the second line use, so to me, I think most of the evidence is still, heavily on second line therapy. Well, based on what I saw in the abstract, I think there's definitely, evidence, perhaps not as strong as the original study because this is a subgroup analysis, but it does suggest that there's benefit in second line and first line, at least in my interpretation. I think in Canada, the treatment landscape or the funding landscape typically is based on the original phase 3 study. So, putting on my funding hat, I think, its use is probably most strong in the second line. But again, this is a very, still a relatively rare tumor. And we have to, base treatment on the best available evidence. So I think if we were in a situation where we have very limited options, I think I would still feel relatively comfortable in using it in first line as well. I would say yes. That's my short answer. It kind of circles back to my earlier point that this is still a very morbid disease, high fatality rate, and we really want to exhaust all lines of therapy. And I think it's always encouraging to see nowadays that we're talking about multiple lines of therapy because just 5-6 years ago, there's only one treatment option. So the fact that we're even talking about multiple lines of therapy is excellent for patient care. And as a clinician, I think it always makes our job a little more, a little easier when we can offer patients more and more options. I think if they're fit enough and the performance status is good enough, I'll definitely consider it. I think the caveat here is that there are some individuals who are quite frail after after gemcitabine monotherapy. So so I think there will be a subset that we cannot offer any therapy. That's not specific to nal-IRI. But hopefully, as we get better with treating patients, they'll be more fit and more able to tolerate second line therapy, such as nal-IRI.